graciously accepted to be our guests of honor. They are Dr. K.K. Parikh sir, the president of IACM, and Dr. G. Narsimlu, past president of IACM. Dr. K.K. Parikh sir, past president API and the current president of Indian Academy of Clinical Medicine, needs no introduction at any forum. It was his idea to have these online CMEs, and he has worked tirelessly. He removed all the roadblocks we encountered all along the way. And when we are sitting today for these CMEs, it is largely due to his efforts. He is the heart and soul behind these CMEs. Sir, it is an inspiration and an honor to be associated with you. I will now request you to say a few words to all the people who have joined, our chairpersons and our moderators. Thank you, sir.
Thank you, dear Dr. MP. It's really a great pleasure in welcoming all of you to this 4th virtual CME program of Indian Association of Clinical Medicine. Our guest of honor for today's function, Dr. G. Narsimlu, very close friend of mine and past president of Indian Association of Clinical Medicine and past dean of Indian College of Physicians, a great academician of great repute and very humble person. Our chairperson, Dr. and Professor MPS Chawla, whom I can't see because he works behind the curtain, and is one of the very dynamic editor of Indian Academy of Clinical Journal of Indian Academy of Clinical Medicine, and because of him only we are getting this journal, and I think it is one of the topmost journal of in medical faculty, and the credit goes to the IACM faculty members and Dr. Chawla. Dr. Chakravarti, DP Chakravarti, Organizing Secretary of IAMCon 2023, a very dynamic person, and we hope to see him in IAMCon 2023. Dr. B.B. Rewari, past president of IACM, great academician, person master of his subject, HIV of international level. So he's a moderator and he's a speaker himself. Then Dr. Deepanjan, past president of Indian Academy of Clinical Medicine. Our learned faculty members and masters of subject, Dr. Pulin Gupta, will be talking on management of common opportunistic infections in patients suffering from HIV. Dr. B.B. Rewari will be talking how do I manage HIV in an infected person in my clinical practice. So thank you all the legends of IACM for your presence and sparing your valuable time to grace this occasion. And in the last, I would like to extend my sincere thanks to the backbone of these CME programs and coordinator of these virtual CME programs, Dr. MP Singh, for his untiring efforts to make this CME program very successful. I would also like to welcome Dr. Girish Mathur, President of API, who is very kindly present here to this occasion, and I welcome him and thank you for attending this CME program. Thank you very much. So, Dr. Narsimlu?
Yeah, yes, sir.
Yes. One announcement, we are having a CME program of IACM, an inaugural function of state chapter of IACM Rajasthan chapter on 26 July in Hotel Clark Sambir. I request everyone to please block your dates for this program from morning 10 o'clock to evening 8 o'clock. So please block your dates, and I request to kindly attend the program. With the formal invitation will be sent to you, and program will also be included in that one. Thank you very much. Dr. Narsimlu, sir.
Yes,
Thank
sir.
you, sir.
Thank you. Welcome, sir.
Thank you, sir.
Thank you,
It is
Parikh,
a pleasure to see.
Thank you, sir, for your words of wisdom and blessings. I now extend a very warm welcome to our former president, Dr. G. Narasimhalu, who has very kindly and graciously accepted our invitation and is our today's guest of honor. Sir is the current professor and head rheumatology at ESI Medical College and Super Speciality Hospital, Hyderabad. Sir has been former professor and head rheumatology at NIMS, Hyderabad. It was under his guidance and able leadership that the first DM in rheumatology, the first DNB in rheumatology, and the first fellowship in rheumatology anywhere in India was started under him in Hyderabad. Sir has been president of Indian Rheumatological Association. He has been past dean of Indian College of Physicians. He has been awarded numerous orations and has also been a recipient of Dr. M.C. Gupta oration in IACM. Sir was president of IACM in 2009 and 2010. So I extend a warm welcome to you, and we'd love to hear from you and have your blessings for our association once again.
Thank you, Dr. MP Singh, for your kind words. As outset, my friend Dr. Parekh, he is one of the noble man, good friend of mine, like my elder brother. He's the president of IACM, former president of API and dean of API. His contribution to IACM enormous. It is my pleasure to see him after a long time, and it's a sweet words, encouraging for everybody. And Dr. Chawla, he is a very active member of API and also IACM. And Chakravarti, very active member of IACM. And Dr. Rivari, my old and good friend, very dynamic person. He's a dynamic soldier and patriotic soldier, rather than patriotic soldier of IACM. And he started journal. And today IACM, his contribution I can't forget. And Dr. Dipanjan, one more, a staunch soldier, a patriotic soldier of IACM. Welcome, Dr. Dipanjan. Thank you for calling me. And Dr. Rivari is an authority in HIV, and nobody can deny that. And he contributed a lot in HIV. And Dr. Pulin Gupta is one more great leader of IACM. It is my great pleasure to accept this invitation of IACM. I'm the founder member of IACM. We have two conferences in Hyderabad, and it was very active. And once again, I would like to see one conference of IACM in Hyderabad shortly. And I wish this CME a great success. And I'm very happy to know in Rajasthan State Chapter organizing a state conference in the month of July. I love to be there. I had some family casualty. All my friends knows. I was last 1 month busy in taking care of my wife, and she's recovering now with the blessing of all my friends. And with this CME, a great success, and will enlighten HIV. I want Rivari make a plan to eradicate HIV from the globe. Thank you, Rivari ji. Thank you. Back to our friend. Dr. MP Singh, take over, please.
Dr. MP Singh, please
MP
unmute
Singh.
yourself. You need to unmute.
And my compliment to Dr. my friend, Dr. Girish Mathur, president of API. I'm not able to see him.
Thank you, sir. Thank you for your blessings and your words of wisdom. I would now like to welcome Dr. Dipanjan Bandyopadhyay, sir, the young, efficient, and ever dynamic past president of IACM. In fact, the youngest ever president of IACM. Sir is also an authority on HIV, and who better than him to be the moderator for today's program? Sir, please hold the proceedings further.
Unmute, sir. Unmute Dr. Dipanjan.
Dr. Dipanjan, sir, please unmute yourself.
Good evening, everybody. I think at the outset, we should congratulate Dr. Singh, and we should also congratulate Dr. Parekh for giving us this leadership in organizing these online meetings and online conferences and CMEs. It's really a pleasure to introduce the chairpersons of today and also to be a co-moderator with Dr. Rivari. I have a very long personal association with Dr. Rivari, and Dr. Devaprasad Chakraborty is basically a very old friend of mine. It's really lovely to see him on the IACM platform today. He is a dynamic clinician. He is presently the professor and head of medicine at Agartala. And we are looking forward to a wonderful conference at Agartala. So we have a lot of expectations from Devaprasad. And thank you, Devaprasad, for joining today despite your very busy schedule. And Dr. Chawla, our learned editor, he's almost a guardian figure to me. It's a pleasure inviting sir as well. So maybe Dr. Chawla and Dr. Devaprasad can please continue the session for this evening.
I think
Yes,
first
Devaprasad.
speaker is Pulin. First speaker is Pulin, I believe. So
I would request Dr. Devaprasad Chakraborty to introduce Dr. Pulin Gupta, sir.
Okay. Good evening, everyone. Greetings from IACM Tripura State Chapter. Before I go on to introduce the learned speaker for this CME, let me make an announcement because Dr. Dipanjan has already set the ball in this forum that we are organizing IACM Con 2023 at this beautiful city of Agartala. Yes, obviously it's the best month of Agartala otherwise also. So I'll request all of you to block your dates from 24th to 26th of November and come down to our place to have this mega academic event of IACM and explore the flora and fauna of this place. The organizing committee has started working hard to make it a real good success. And I'll request all of you present in this forum to please join us and encourage your colleagues and friends and PGTs to come down to Agartala for this conference. Regarding this session, which will be delivered by Dr. Pulin Gupta, he is an eminent faculty is a professor of medicine at Dr. RML Hospital, New Delhi. He is also the adjunct professor at Loyola University, Chicago, USA. He happens to be the member secretary for Board of Studies, IP University. Sir has many awards and achievements and publications to his credit. Dr. Gupta will talk on management of common opportunistic infections among people living with HIV. With these words, I'll request Dr. Pulin Gupta please start his deliberation.
Thank you very much. Respected all my seniors, my teachers, obviously Dr. Girish Mathur and Dr. KK Parekh, Dr. Narsimlu, my present head of department, Dr. M.P. Chawla, Dr. Rewadi, a person who brought me to this level in HIV. So since it's a short time, let me start. I have been assigned to speak upon the opportunistic infection in people living with HIV/AIDS. So you see, first of all, we should try to understand. I don't know whether there are some postgraduate students also, because I have sent this message to my PGs at least. So OI is a disease which is caused by a microbial agent in the presence of a compromised host immune system. That means you can easily predict whether CD4 level is going down. You can predict at what level, what particular OI is bound to happen. Let me show you a slide. So when the CD4 count is 400, you know, now it is a time herpes can attack, whether it is simplex or zoster. Tuberculosis can happen at any time, but obviously when the CD4 count is less than 350, tuberculosis pulmonary as well as extrapulmonary tuberculosis can happen anytime. And when the CD4 count is less than 200, the most dreaded one, pneumocystis, pneumonia, esophageal candidiasis, and if it is less than 100, then cryptococcal meningitis.
Slides are not moving. If you are you? I'm sorry, the slides are not moving.
So it's moving.
Can you make it full screen and then share slides?
Sir, slides are visible, but only the slide show has to be done. Slide show.
Just a minute. Let me check.
Yes. No.
Just a minute.
तो स्क्रीन शेयर कर रहा है ना पुलिन?
हाँ जी सर.
तो फिर उसमें नीचे देख बेटा स्लाइड शो होगा, उसको कर.
Yes, yes. Good. Last time, yes. Lastly, you have done it.
So this is good.
Yes. But again, no. Anyhow, we can go with it. But
It is not. Can you
there
please
is
see?
no movement in this slide of the slides. Slides move नहीं कर रही हैं सर.
Hmm.
आपने move की slides?
So double click it. It was saying double click it to make it full screen.
Are they moving right now?
करिए. ना, नहीं move रही.
They're not moving, sir.
Yes, it is full screen. Now you can move it. Yes.
It is not
Move
moving
it.
from my side.
No,
So if
it will-
someone from the team,
Sir, I have shared your slide, sir. I have shared your slide. Please, you
you
continue.
will change the slides.
Yes,
Yes,
he will,
yes,
he
yes.
will, he will change the slides.
Okay, next slide, please. So you can see when the CD4 count goes down. Next slide,
Yes.
please. For example, if the CD4 is less than 400, you can predict it is either herpes zoster or herpes simplex, which is standing in front of you. If it is less than 300, 350, tuberculosis, oral candidiasis, less than 200, pneumocystis pneumonia, esophageal candidiasis, and when it is less than 100, then all your enemies, which can take the life of a person living with HIV/AIDS, including toxoplasmosis, cryptococcosis, and all causes of chronic diarrhea, PML, this can come into picture. Next slide, please. So that is why knowing what particular OI happens at what CD4 level is quite important to us, because that not only dictates us how cautiously we have to move, that also tells us what is the type of prophylaxis we need to give to this patient. So you see, what are the common OI seen in India? As far as bacteria are concerned, these are more or less the same bacteria which happen in a general population, although in a patient of HIV, this is much more common. The difference lies in the viral, the fungal, and the parasites. Amongst the viral, the cytomegalovirus, human papilloma, JC virus, these are something which is very peculiar seen in patients with HIV/AIDS. As far as fungal is concerned, obviously we know that cryptococcal neoformans can happen even in an immunocompetent host, but otherwise 99% of the time, you see pneumocystis xerovicei, cryptococcus, and penicilliosis, histoplasma in people who are HIV infected. Similarly, parasites, again, toxoplasma, then intestinal parasites like cryptosporidium, isospora. These are seen more commonly and almost exclusively in people with HIV/AIDS. Next slide, please. So what are the common presenting symptoms? Most common presenting symptom, whatever is the OI, whether it is an OI involving the respiratory system or the GI system or the CNS, it is the weight loss and fever, which is the most common presentation. Apart from that, diarrhea, weakness, fatigue, cough can happen in many OIs. Next slide, please. So when we go ahead for speaking about OI, let me speak first about tuberculosis, the main disease, which is, it is said that almost 50 to 70% of people living with HIV will have tuberculosis, whether it is pulmonary or extrapulmonary, once in their lifetime. So you see, once someone is infected with HIV, the chances of having active tuberculosis is 16 to 27 times in India and almost 100 times, this is a figure, 100 times throughout the world. So that's the basic problem. And it is not the only thing. The problem is that the HIV people are already immunocompromised with a low CD4 count. When they are infected with HIV, with tuberculosis, the viral replication increases by 6 to 7-fold, and exponentially the CD4 level goes down. So that's the problem. It is a synergistic action of both the disease. Each disease is supporting the another one, and who is taking the toll? The patient and the physician is taking the toll. And there is a 3 to 10% per year risk of getting tuberculosis in any person who is infected with HIV. Next slide, please. So most of the patients present with fever, cough, dyspnea, weight loss, etc., the pulmonary as well as extrapulmonary in early stages of HIV, 80% people have pulmonary tuberculosis. However, when the CD4 count is low, extrapulmonary tuberculosis is seen to be almost the same as pulmonary tuberculosis. The problem lies with the fact that many a times there is an atypical presentation. The presentation may overlap, like tubercular meningitis may look like a cryptococcal meningitis. And as far as the X-ray findings are concerned, the typical apical involvement cavitation is not seen in pulmonary tuberculosis, which happen in HIV positive individual. Rather, it's a diffuse bilateral infiltrates, hilar lymphadenopathy, pleural effusion, cavitation is not seen very commonly. Lower lobe involvement, that bilateral, And biliary pattern is quite common in people with HIV and tuberculosis. Next slide, please. So how do we manage these patients? Remember, CB-NAT is one test which is now coming into picture in all people who are infected with HIV and having these 4S symptoms. So all these patients should go for a CB-NAT testing. If it is positive, declare these patients as HIV with tuberculosis, rifampicin resistance. If it is there, you need to change the treatment. And if the patient is rifampicin sensitive, do a LPA also, and then rule out a isoniazid resistance, because multi-drug resistant tuberculosis is up to the tune of 3 to 5% of all the tuberculosis which happen in a HIV positive individuals. Not only the patient will die because of MDRD, but this patient is bound to transmit this particular MDR type of bacilli throughout other people also. Next slide, please. So, coming back to the respiratory symptom, let's speak about some OIs which are seen to present as something related to the respiratory symptom. So you have a patient with fever with respiratory symptoms. If it is CB-NAT positive, with X-ray positive, CB-NAT positive, X-ray normal, or even CB-NAT negative and X-ray suggestive of tuberculosis, these patients should be started on tuberculosis as early as possible. Now, there are some patients who are CB-NAT negative and chest X-ray is not typical of tuberculosis. So what other disease? What other disease? It is actually pneumocystis probably, which presents as the bilateral interstitial infiltrates, ground glass appearances, opacities. And the main thing is that although the clinical findings are very subtle, the patient is very much symptomatic. And hence we need to treat these patients as early as possible on empiric basis. We'll get the investigation done lately, but start treatment as early as possible, along with plus minus steroids also. Next slide, please. So next slide, please. Let me come to a case. So this is a 30-year-old man, patient with CD4, 150, 200, comes with fever for 3 days, chills, breathlessness. What's the diagnosis? We know that it looks to be a lobar pneumonia. Next slide, please. And hence, this patient should be treated with as a case of lobar pneumonia or maybe bilateral pneumonia. In the same way, we are treating the immunocompetent people with amoxicillin clavulanate plus minus azithromycin. The duration is 7 to 14 days, depending on the response. Next slide, please. Again, next slide, please. So now we have another patient. This patient, a 27-year-old person with 2 weeks of progressive breathlessness and a relatively dry cough. See, I'm repeating, dry cough. Because you see, sputum production is not a common presentation of pneumocystis pneumonia. It can happen, but it will be very, very minimal. So you see the respiratory rate is 42, oral candidiasis is present, that means the CD4 count is low. Clinical signs are very subtle types, bilateral fine, late inspiratory capitations, no bronchial breathing, no as such lymphadenopathy you can see. What is the differential diagnosis? Keeping in view the CD4 count, keeping in view the presentation, 2 weeks, saturation low, looks to be a patient of pneumocystis pneumonia. Next slide, please. It's a type of fungal pneumonia which is associated with a high mortality if you do not pick the patient timely. Next slide, please. So you see the typical chest X-ray finding are bilateral fine interstitial shadows with prominent perihilar distribution, the ground glass appearance, and there is disproportionate hypoxemia. Disproportionate hypoxemia, that means in proportion to the low saturation, the patient is not showing any significant signs, the respiratory system examination signs. Next slide, please. Again, next slide, please. Next, please. So the treatment, we all know that we have to start the patients on cotrimoxazole therapy. But remember, cotrimoxazole, apart from that, one another drug which reduces mortality significantly is steroids, and especially in patients with moderate to severe type of disease. So all patients with PO2 less than 80 should be treated with steroids as early as possible. And in severe, you cannot wait. All these patients should be admitted. If they are not on ART, please don't start ART right now. Wait for 2 to 3 weeks till the time the treatment for OI is over. Next slide, please. So what's the treatment? Treatment, we all know it's cotrimoxazole, trimethoprim, sulfamethoxazole, double strength tablet marketed as Septran or Bactrim, available in the DSEX, the States AIDS Control Society, and NACO. 2 tablets thrice a day, 3 times a day, and the treatment should be continued for 21 days. And if it is moderate to severe disease, Start with prednisolone, 40 milligram twice a day for 5 days, once a day for 5 days, and then 20 milligram OD for the next 11 days. That means again, the same duration when you are giving Ceftriaxone, that is 21 days. However, a whole lot of patients are there who are sulfur sensitive. For these people, give trimethoprim along with dapsone, or even pentamidine inhalation is available. If it is not available, there is one drug, clindamycin, which is now available in each and every tertiary care center of India. Atavacone is, I do not know whether it is available easily or not. But again, most of these patients do respond very well to cotrimoxazole. And if someone is not responding, obviously it's an emergency. You can start patient on dapsone and trimethoprim also. Next slide, please. Then there are some other fungal infections also. I won't go into the detail apart, but let us realize that histoplasmosis is one disease which presents as a multi-organ involvement. The patient will come to you with fever, breathlessness, altered sensorium, headache, some meningismus, some abdominal complaint, diarrhea, and respiratory syndrome also. Antigen in blood and urine is a good test to pick that up. And since it's a fungus, the treatment is again amphotericin B followed by itraconazole for 12 months. The mortality is quite high if you miss these patients. Next slide, please. So this was all about the respiratory symptom. Now coming to the mouth and throat. Why? Because oral candidiasis is probably the most occult, the easiest type of OI which happens seen in almost all of the patient, but missed many a times. And remember, there are two things. One is odynophagia, one is dysphagia. If patient is presenting with the painful eating odynophagia, it is oral candidiasis. However, if these people with oral candidiasis present to you with substernal pain, that's dysphagia, please try to look upon and rule out a esophageal candidiasis, because remember, any OI which happens in a patient of HIV reduces CD4 count by itself. So please treat all this. It's better you prevent any OI, but if it is there, treat it as early as possible. The treatment between the oral as well as esophageal candidiasis is poles apart. Next slide, please. You can see the presentation. The oral cavity looks like that. There are chalky plaques which on removal do not bleed. They can be easily removed. Next slide, please. However, if you compare this with oral hairy leukoplakia, which is again, next slide, please, which is again a type of opportunistic infection caused by Epstein-Barr virus. It is a white plaque which is found on the lateral border of tongue, which is not easily removable and bleeds if you forcefully remove it. Next slide, please. So once a patient has esophageal candidiasis, the endoscopy will be typical like this. There will be white patches followed by a normal looking or either erythematous area, which you call as a tram track pattern. Next slide, please. Now, the thing is that if a patient comes to you with oral and esophageal candidiasis, how to treat? Remember, with oral candidiasis, most of the patients can be treated with topical clotrimazole therapy 3 to 4 times a day. But if the patient is still symptomatic 5 to 7 days after this treatment, either add a fluconazole oral tablet 100 milligram per day for 7 to 14 days. Again, still if the patient is symptomatic, keep in mind that it can be herpes virus infection also, and you can start acyclovir on empirical basis. However, if it is a esophageal candidiasis, immediately start fluconazole 200 milligram once a day for 14 to 20 days. And the patients of esophageal candidiasis who do not respond to amphotericin B, do not respond to fluconazole, plan to start amphotericin B in these individuals. Next slide, please. So this is the next slide, please. So as far as esophageal candidiasis is concerned, there are some other disease which presents with esophagitis. The worst is cytomegalovirus esophagitis. Can you come to the previous slide, please? Now, cytomegalovirus esophagitis is again, it presents with dysphagia. Remember, most of these patients have some retinitis. So if you encounter a CMV esophagitis, immediately send this patient for a fundus examination with full dilatation, because this patient is bound to have retinitis or maybe colitis also. And the treatment again should be started as early as possible. Then herpes ulcer and in fact, HIV associated ulcers can also happen. And blood test, antigen detection won't help in these individuals. Next slide, please. So this is just the presentation. You can see the candidal esophagitis versus the herpes simplex esophagitis versus the cytomegalovirus esophagitis. This is more of a theoretical knowledge presenting, but again, we should be very, very cautious that all patients of candidal esophagitis who are not responding to routine treatment, keep in back of your mind that it can be herpes simplex or even cytomegalovirus esophagitis. Next slide, please. So now coming to the GI system. OI is affecting the gastrointestinal symptom. The most common presentation, of course, is diarrhea, seen in 90% of people who have HIV. The problem, or you can see the unique feature, is that diarrhea in these individuals is maybe because of the normal microbes which are causing diarrhea in a normal human being, or maybe because of some parasites which are not commonly seen, or maybe a combination of many of these. Then not only the pathogen is more invasive, apart from that, it is more resistant to treatment. And for some of them, like Cryptosporidium, the treatment is not very effective. That's why recurrence rate is very high. And the pathophysiology is that the immune breach has gone down in the intestine. The local IgA levels are less. And because of the lesser gastric acid secretion and nutritional deficiencies, the growth of these parasites is found to be higher as compared to normal people. Next slide, please. So what are the common organisms amongst all the people where you can isolate, amongst all the HIV positive people where you can isolate a microbe? 60% are found to have either Cryptosporidium or Isospora. But by God's grace, at least the treatment for Isospora is very good. In fact, for Cryptosporidium also, Nitazox does well. I won't say wonderfully well, but it does well. Next slide, please. So you see for all those patients who present to you with chronic diarrhea of more than 2 weeks duration, please ask oocyst, the fecal examination for oocyst with the acid-fast stain. You need to write it. If you do not write, but pathologist is not a god. They do not understand what you are asking for. So the resident needs to write this thing. And you see for Cryptosporidium, it's a small one. For Isospora, it's a larger oocyst, deep pink in appearance. For Cyclospora, again, dark red. And the treatment for Cryptosporidium, Isospora, and Cyclospora all is available to us. For 2 of these, for Isospora and Cyclospora, the treatment is the same. But you need to pick up the Cryptosporidium as early as possible because number 1, nitazoxanide is a separate drug which is to be given. Number 2, nitazoxanide does not do so well, and hence ART should be started as early as possible in these people with Cryptosporidium diarrhea. Next slide, please. Most of these parasites, they involve the small intestine. So what happens? Small intestine is the site where all the carbohydrate, fats, proteins, minerals, vitamins, iron, blah, 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 blah is absorbed. So these patients they develop malabsorption syndrome. They become weak. The nutrients are not absorbed. And because of this, the CD4 level goes down. The immunity goes down. So it is a double-edged sword which we are facing. We are seeing HIV. On top of that, we are seeing a disease, a OI, which by itself is reducing the CD4 count and increasing the HIV viremia. Next slide, please. The management we know for Cryptosporidium, nitazoxanide 500 to 1000 milligram twice a day for 2 weeks. For Isospora and Cyclospora, it is cotrimoxazole tablet, double strand twice daily for 10 days. Then a prophylaxis to be given. For Giardia, etc., you can treat in a normal way like we are treating in our daily clinics. Strongylides is one particular protozoa which is seen more commonly in people with HIV/AIDS. But by God's grace, treatment is very effective. Ivermectin in a single dose does act beautifully in these individuals. Next slide, please. So coming to the CNS manifestation, the OI is coming into picture with a CNS type of presentation. It can be a global type of presentation like you see in tuberculosis, tubercular meningitis, cryptococcal meningitis, or a focal lesions like you see in a tuberculoma, histotoxoplasmosis, PML. Then encephalitis, again seen very commonly with cytomegalovirus infection and herpes simplex, myelitis, and last but not the least, neurocognitive decline, what you call as HAND. But HAND is because of HIV by itself, and with the early institution, as early as possible institution of ART, the prevalence of HAND, which was once upon a time 70 to 80%, has gone down to 40 to 50%. That's the beauty of ART, which should be started as early as possible. Next slide, please. So you have a patient which comes to you with headache. How do you approach? So the patient is either presenting with a global one or presenting with a focal type of presentation. If it's a global one, patient with fever, neck rigidity, vomiting, altered sensorium, first of all, get an NCCT head, fundus. If there is no papilledema, get a CSF done. Check the WBC count, protein, glucose. Apart from that, the CBNAT should be done in all these patients, and India Inc. gram stain culture. If if there is a patient who comes to you with chronic meningitis in a patient of HIV, the first differential which should come to our mind is cryptococcal meningitis. After that, we should think about tubercular meningitis. Until and unless a cryptococcal meningitis is ruled out in a patient of HIV, it's a crime to say that this person is having tubercular meningitis. And culture sensitivity should be sent in all these individuals. On the other hand, a patient presenting with focal presentation, seizures, sign, monoparesis, get a contrast enhanced MRO CT. If it's a ring enhancing lesion, it can be tuberculoma, neurocystic sarcosis, toxoplasmosis. However, if it is normal, again go back to the lumbar puncture and CSF analysis. Next slide, please. So, how do we manage these patients? These patients are normally very sick, very toxic, and the chances of dying because of intracranial edema is very, very high. I'm going to show you a slide which shows that in patients with cryptococcal meningitis, the chances of death increases very, very much when the intracranial pressure is high as compared to those people who have a normal intracranial tension. So pick up the causative organism, treat them with the definitive treatment. Don't start ART right now. Wait for 2 to 3 weeks. Please avoid immune reconstitution syndrome because IRS, if happens in these patients, it causes suddenly a raised ICT. And that becomes a problem, whether to stop ART or not, whether to give steroids or not. And remember, drug-drug interaction, especially ATT with dolutegravir, is to be taken care of. Next slide, please. So let me show you a case. This patient presenting with low CD4 count and headache, vomiting, neck stiffness, fatigue, altered sensorium. We know. What do we see? This looks to be molluscum, but actually it's a cryptococoma. Next slide, please. So we are dealing with a case of cryptococcal meningitis. Now, the opening pressure, if it is possible to check, please do check it, especially in tertiary care centers. That's not a problem where there are a lot of residents. If it is very high, because that makes a difference in total mortality, prediction of total mortality. As far as CSF counts are concerned, WBC counts are not very high, just 10 to 15. Protein is not very high, glucose is not very low, CB-nat is negative. Next slide, please. So what do? Please go for a India Inc. Next slide, please. India Inc. antigen and culture sensitivity. So to differentiate between a cryptococcal and tubercular meningitis, cryptococcal meningitis, the CSF cells are not very high, protein is not very elevated. But in tubercular meningitis, CSF cell may be 50 to 100, maybe more than that. Proteins are elevated, sometimes xanthochromia, and sugar is quite low. So these patients should be differentiated in the treatment, should be accordingly to the culture sensitivity. India Inc. preparation may be positive in patients who have previous cryptococcal meningitis. Even cryptococcal antigen may remain positive for 6 weeks to 6 months. That's because of the dead fungus. Cryptococcal antigen, cryptococcal culture sensitivity is the only test which will tell you whether it's a relapse or a refractory type of disease. Next slide, please. So cryptococcal meningitis, coming back to that, it's because of a fungus, neoformans or guttae, and usually occur when the CD4 count is less than 200. Presentation, again, we know cryptococcal antigenemia at the time of first visit at ART center, whether the patient is symptomatic or asymptomatic, is a predictor of further cryptococcal meningitis. Even if a patient who is asymptomatic, no headache, vomiting, CD4 count 150, 100, and cryptococcal antigen is positive, this is one patient which will probably have cryptococcal meningitis as a part of IRS when you are going to start the treatment. The problem is that neither the physician is willing to do a CSF, nor the patient is going to give a consent for LP, and to differentiate between the new and relapse cases is very, very difficult because culture sensitivity is not possible everywhere. Next slide, please. So the management, we know it is amphotericin B. If it is liposomal available at your center, beautiful. If it is not, at least start deoxycholate. Keep in watch the KFT, the serum creatinine, and the potassium levels. So M4B along with flucytosine for 2 weeks, then fluconazole. After the induction therapy, go for the consolidation therapy with fluconazole 800 milligram once a day for 8 weeks, then the maintenance therapy till the time the CD4 count is more than 200 to 250 at 2 separate occasions, separated 6 months apart. That's the major thing. Adjunctive corticosteroid therapy is not recommended in these individuals. Next slide, please. As I told you before, it is the increased intracranial pressure, which is again a predictor of mortality in these individuals. In patients with intracranial pressure more than 350, the mortality is 38% as compared to 21% who have less than 250. So all these patients who have high CSF pressure, therapeutic lumbar puncture and CSF drainage of 30 ml should be done every second day. Next slide, please. Again, next slide, please. The problem is that if you are planning to do a shunt, the shunt thrombosis, shunt infection, and dissemination of cryptococcal to the peritoneal cavity is also seen to be quite common. So this is another case. A patient HIV positive comes to you with seizures, monoparesis. You can see some ring enhancing lesion in the gray matter of area with perilesional edema with mild midline shift. What is the diagnosis? Again, absolutely clear. We all know it is probably toxoplasmosis. Next slide, please. There are multiple other differentials like tuberculoma, neurocystic sarcosis, brain abscess also. But these, next slide, please. But these patients should be serum IgG level should be done immediately in these individuals. Next slide, please. Next, please. So serum MRI, contrast enhanced MRI should be done. You can see multiple ring enhancing lesion in the gray area, and ELISA for IgG is positive in almost all the patient. It is positive even in us also. But again, IgG, if it is negative, that almost rules out toxoplasmosis. And we cannot go for a brain biopsy. So that looks to be the only investigation which gives you a clue that immediately start the treatment in these individuals. Next slide, please. So how do you treat these individuals? Pyrimethamine plus sulfadiazine. And if pyrimethamine sulfadiazine is unavailable, again, Ceftriaxone looks to be a good drug which can be used in these individuals. Alternative regimes are there like cotrimoxazole, as I told you. Apart from that, pyrimethamine plus clindamycin is there. Total duration is 6 weeks, and maintenance therapy with cotrimoxazole 1 tablet daily is required till the time the CD4 is more than 200 for at least for 6 months. Next slide, please. Now we have another patient looking similar, but you see here the edema is in white matter, not in gray matter. There is no perilesional edema, no midline shift. CD4 is very, very low. The patient is otherwise alert, no optic nerve involvement. Simple straight diagnosis. It is PML, JC virus infection. Next slide, please. So to differentiate PML from toxoplasma, PML is a disease of white matter. Toxoplasma is a disease of gray matter. PML, the patient may presents with cognitive dysfunction, and headache and fever is not characteristic. The patient may be conscious also. With slowly progressive disease, sudden onset, it is not a sudden onset disease. Ataxia, aphasia, cranial deficit, except optic nerve. May present with hemiparesis, quadriparesis, monoparesis. Seizures do happen, and normally spinal cord is not involved. Next slide, please. So this is, we know this is all because of the JC virus. There is no as such treatment available for this particular virus. The only treatment is start ART as early as possible. This is one amongst those few OIs where ART should be started. It is only cryptosporidium and PML where ART is the treatment which should be started as early as possible. PCR methods are there, although not available in each and every center. And remember, PCR negativity does not mean that the patient is not having PML. So if you have a typical MR finding, start treatment as early as possible with ART after ruling out other OIs also. Next slide, please. So now coming to the end, let me speak something about the ocular manifestation. HIV by itself can cause some ocular manifestation, but apart from that, cytomegalovirus retinitis do occur very frequently in all patients with cytomegalovirus esophagitis. The first thing, I repeat, the first thing you do, send this patient to ophthalmologist, write that probable CMV retinitis because he needs to do full dilatation. The initial changes may start peripherally, and if fundoscopy is not done after dilatation, the early changes may be missed. And the CMV retinitis becomes a necrotizing retinitis where the permanent loss of vision may happen. The patient may present with a floater or scotomas or peripheral visual field defects. But again, a good fundoscopy is essential, and we need to discuss, we need to talk to the ophthalmologist to rule out this particular infection. Next slide, please. So how does it look like? See, it's a typical presentation. There are, you see, it's called a brush fire pattern with a white leading edge advancing much before a gliatic area, yellow-white retinal lesion with some hemorrhages, which you can see in the second pic. The treatment is, if the patient is, it's a sight-threatening lesion, intravitreal ganciclovir or forced Carnet can be used. Not available in many centers, probably all Indian students. Some limited centers are doing like that. But ganciclovir orally or IV ganciclovir, which is given free of cost by the State's AIDS Control Society, are a promising drug which should be started as early as possible in these individuals. Next slide, please. So maintenance therapy again should be continued till the patient is having CD4 count more than 100 with valganciclovir, but it's a very, very expensive drug also. Next slide, please. So while coming to the end, let me show you some slides about herpes zoster. Normally, this is not a typical herpes zoster. This is a multi-dermatomal herpes zoster. This is not seen commonly in immunocompetent people. Again, it should be treated as early as possible, because if the patient is not treated on time, the pain is really debilitating for these individuals. Next slide, please. Treatment, the drugs are available very easily everywhere. Either use acyclovir 800 milligram 5 times a day, or better use valcyclovir if the patient can afford 1000 milligrams 3 times a day for 7 to 10 days. Next slide, please. So this is again, the first is molluscum contagiosum. We have seen this. The second is cryptococcosis, and the third is penicillium. The central necrotic black area is almost specific for penicillium. Next slide, please. So what is penicillium? This is next slide, please. So this is particular disease which is found in the northeast part of India, especially Mizoram, Manipur, and it is a stage 4 AIDS defining illness. The patient presents with multi-organ involvement, fever, lymphadenopathy, hepatosplenomegaly, anemia, pancytopenia. Mortality is quite high if the patient is not diagnosed on time. Since it's a fungus, again, the treatment is amphoby followed by itraconazole, which does wonderfully well in these individuals. Next slide. So that was all about the common OIs, but before ending, let me tell you, next slide, please. It is not the treatment, it is the prevention which is necessary. And hence, before starting OI, please rule out, before starting ART, please rule out any opportunistic infection so as to prevent immune reconstitution syndrome. The compliance should be managed. Now with the single once-a-day tablet of TLD, the compliance should be good, and it is the duty not only of the counselor, but of the doctor and every person that we need to talk to the patient that compliance is a must, along with good food habits and absolute abstinence of smoking and alcohol. Prophylaxis with cotrimoxazole is absolutely necessary in all individuals with CD4 count less than 350, not only to prevent pneumocystis pneumonia, but to prevent many organisms which can cause chronic diarrhea also. The isoniazid preventive therapy has done wonderfully well, especially in preventing the tuberculosis as a part of IRS. Next slide, please. IRS, if I'm speaking about, we know what is IRS. So before starting ART, make it sure that the patient is not having any OI, except PML and cryptosporidium, where it is a treatment. But please rule out any active OI in these individuals after a thorough checking. Next slide, please. So while coming to end, let me just recapitulate the fact that opportunistic infections are quite common in HIV. In fact, the cause of death is opportunistic infection. We need to have a syndromic approach. The type of OI, you can easily predict the type of OI by looking upon the CD4 count, and the CD4 count drops down, OIs do come. When the OIs do come, the CD4 count again drops down. So you need to pick up OI as early as possible, because most of them are treatable with specific drug, and don't be in a hurry to start ARD. We need to prevent iris also. Next slide, please. So by this, I would like to end. Thank you very much. Jai Hind.
MP Singh, are you there?
Yes, sir, I'm there. We can see you now, sir. Please go ahead.
Okay, fine. So I think we'll take question answers at the end of our update.
Sure,
So
sir.
now I have the pleasure to introduce a very dear friend, Dr. B.B. Rewadi, with whom I have an association of close to 30 years. And he is one man who doesn't need any introduction, especially to the IACM people. He has been president of IACM. He has been editor of Journal Indian Academy of Clinical Medicine. He has been past president of API, and now he is vice dean of Indian College of Physicians. And he is the regional advisor for Southeast Asia for HIV and for sexually transmitted diseases and for hepatitis. And he has been awarded, I don't know how many awards he has got, but he's a decorated doctor, I would say. And who better than him to talk about treatment of HIV, because he was the person who was involved in rollout of antiretroviral therapy by NACO in India. So, and this on the horizon, many things they have changed. We are talking of injectable drugs. As far as compliance are concerned, now we have injectable drugs. We have a lot of new things in pre-exposure and post-exposure prophylaxis. And even vaccine, I believe, is not that far away. So over to you, Dr. Rewadi. And I would request you to conclude it in time so that we can have some time for discussion also.
Thank you, Chairperson, and the organizer for giving me this opportunity to present my talk on how do I manage an HIV infected person in my practice. So I'll be restricting a little bit to the clinical management guidelines rather than moving on to what are the future directions. But very importantly, I would like to highlight on the role antiretroviral therapy has played. We know that HIV is now 42 years old. I mean that it was detected 42 years ago, 5th of June, 1981. More than 4 crore people have died of HIV. 3.8 crore people are living with HIV. And coming to Indian scenario quickly, we have 24 lakh people estimated to be living with HIV.
Lights are not moving, Dr. Rewadi.
I've still not started the slides. I'm
Yes,
just
yes,
giving
that's
a
correct. And try to make it full screen.
It's full screen, sir, on my side.
अच्छा अच्छा इधर तो नहीं है सर.
So give you an Indian scenario, we have 24 lakh people estimated to be living with HIV, 63,000 new infections every year, which is a 46% reduction since 2010, and 42,000 deaths annually due to HIV, AIDS, and this is 75% reduction. What I'm trying to emphasize with giving these statistics at this odd hour in the day is that antiretroviral therapy has been a panacea for people who have been infected with HIV. And before I start my talk, I know that most of the people know about ART, what are the ART regimen, and I would like to start with a summary rather than going to all the slides and then summarize. HIV management, ART is one component, as Dr. Pullen has already emphasized that it is important to actually rule out opportunistic infection, provide prophylaxis for them, manage opportunistic infection, and ART is one of the 4 pillars of management of HIV. And antiretroviral therapy, to summarize, basically this is to be provided to any HIV infected person with a confirmed infection, irrespective of CD4 count, irrespective of the viral load. And the preferred regimen is a triple drug combination consisting of tenofovir, lamivudine, dolutegravir, preferably in a fixed dose combination, and monitoring the patient clinically and with viral load at 6 months after initiation of therapy and once every year. So how do we start antiretroviral therapy? So this talk will confirm around how to confirm HIV infection, what is the basic workup before we start antiretroviral therapy, what minimum investigations are required. We don't require a very large number of investigations to start ART. What are the treatment options? How do we monitor patients, and can HIV be cured with antiretroviral therapy? This is very important slide, basically, that we have to be sure that the person is HIV infected, because labeling a person as HIV positive is a big shock. It's not a curable infection. There is still a lot of stigma. Person have psychosocial issues related to the diagnosis, may have suicidal tendencies or depression and other activities. So it is very important that we confirm HIV. Why I'm emphasizing this? Because many times you will get report from a lab which just do one test and label the person as HIV positive, which is not correct. So you have to ensure that the person's report that have come to you is done with 3 different tests. And sorry, I think it has moved to slide show. Just let me correct it. Okay. So this is 3-test algorithm. I will not go into details, but to emphasize that when a person is found to be positive with one antibody test, the person is subjected to test with a different antibody test, that is second. And when he's confirmed with that also, then a 3rd test is performed and a person is reported HIV positive on when all 3 tests are positive. This is important. So whenever you see a report, because we still get reports from some private labs, we just do one test. So be sure that test has been done properly. So when I talk about management, we know that management is a multidisciplinary approach. It is not only a physician. We need to have a lab expert. We need a nutritionist. We need a psychologist. We need to identify a caregiver. And 4 pillars of management are general management, treatment of opportunistic infection, chemoprophylaxis, and antiretroviral treatment. And we have also to keep in mind that we need to prevent the transmission also. So it is very important, like any other patient, we should take a detailed history and do a clinical evaluation. Most important of these is a 4-symptom screening that is for ruling out tuberculosis, that is fever, weight loss, cough, and night sweats of any duration. We should always suspect this to be tuberculosis, and TB suspect protocol has already been emphasized by Dr. Pullen. Any other persistent symptom like headache, poor concentration, seizures, pointing out towards either cryptococcal meningitis, maybe towards this, toxoplasmosis, any sores or white spots in mouth, stomach pain, chest pain, shortness of breath. General history very important, because some of the drugs we are using now lead to elevation of blood sugar, they lead to hypertriglyceridemias. So very important to say history of diabetes, hypertension, any other immunosuppressive therapy. Look for other STIs also. HIV is a STI. Look for other STIs. We often overlook that. Look at the genital ulcer. Look for specific and provide specific treatment for STIs. You also need to ask the risk behavior, because the person may be having multiple partners. They may be from one of the key population, like men who have sex with men, female sex worker, injecting drug users, because we need to test their partners also, offer them advice on partner testing so that we can treat them also. Look for pregnancy, if it is a woman of reproductive age, whether she's on any contraceptives. Look at the family history of TB, which is very important. Look at any previous treatment history, because sometimes people in the past might have taken treatment for some time and then stopped. They might have taken post-exposure prophylaxis sometime. Look for substance abuse. These are very common things, but very often when we prescribe ART, we forget these things and straight away we see the CD4 count or the viral load and prescribe ART. Very important part is look into psychosocial history, look into family history. What are the other immediately family members with known HIV infection? What is the marital status? What is the educational status? Source of income, whether he can afford treatment. If not, refer him to a government center. There are more than 1,200 ART centers providing treatment to almost 15 lakh people free of cost in the country. Look at the disclosure status, whether he has disclosed his status to a family member, a caregiver, spouse. Prepare him to disclose the status and see whether there are treatment supporter available. These all preparatory steps are very important, because ART is very simple. It is a single pill, 3-drug combination, given lifelong. Adherence is important. Drug interactions are important. So it is important that we look into all these issues. And again, to emphasize, intensifies case finding, because even among TB suspects, 8% of those will have HIV, and TB is the commonest opportunistic infection. Almost 2/3 of the people will have TB at some stage during HIV infection. So look for any current cough, fever, weight loss, night sweats, any one of them present, look into the protocol for diagnosis of TB. Physical examination, I don't think I'll go into details of this. You're all physicians, but general examination, mouth, oral cavity, skin for herpes zoster, respiratory examination, other systemic examination, as is done for, because most of the people forget to do these clinical examinations also. Baseline investigation. Don't prescribe all investigation. These are the minimum investigations required for monitoring patient on treatment and ruling out some of the opportunistic infection. Hemogram, urine routine microscopic, only a fasting blood sugar, urea creatinine, bilirubin, ALT. No need to get a full liver function test. VDRL, important to rule out syphilis, CD4 count, surface antigen, anti-HCV, IG if available, X-ray chest, pregnancy test. We also say cervical pap smear for women and for MSM if the CD4 count is low. Some of the additional tests, physicians have their own discretion to decide what other tests are required depending on patient's presentation. Now the question is, do I need CD4 and viral load? Viral load is missing for all PL-HIV for initiation of ART. Answer is no. We don't require CD4 count or baseline viral load for initiation of ART. Before starting ART, it is important to identify current HIV-related illness, coexisting illness, nutritional status, and chemoprophylaxis. Moving to ART, zidovudine was the first drug which became available to be seen as anti-HIV drug in 1985. Then do a 2-drug therapy, 3-drug therapy, but it is a triple drug therapy, which is the standard of care now. And it is, I think, thanks to the Indian pharmaceutical industry, which offered a drug at lower cost, affordable cost, and reduced the number of pills that were required from 32 to 1 pill a day. Indian generic pharma industry has been a game changer globally in terms of scale up of antiretroviral therapy. So these are the different sites of the action. I will not go into details, but these are the key group of drugs, basically where antiretroviral drugs act, and they act by blocking the replication, like reverse transcriptase inhibitors, block the replication from RNA to DNA, integrase inhibitors prevent the integration into the host cell nucleus, and protease inhibitors prevent the budding out of the viruses from the CD4 cell. So these are different group of the drugs that are available. We have almost all drugs available in India. When do we start ART? As I said earlier, this question is no longer relevant because over the time from early 2000, when it was hit hard and hit early, the guidelines kept on changing from 200 to 350 to 500 to treat everyone based on different studies and different trials. And the time does not permit me to go into details. But the guideline now is treat everyone with a confirmed HIV infection, irrespective of CD4 count, irrespective of clinical stage, irrespective of age or anyone. So everyone diagnosed with HIV needs to be treated. How many drugs? This is also not a question now, because we see with monotherapy or dual therapy, the response is limited only to few months. It is only with triple therapy the response is prolonged over the years. And we have patients now continuing over more than 20, 22 years, my own patients from RML who are continuing on the treatment. Earlier, the regimen was tenofovir, lamivudine, efavirenz till 2016. This was the preferred regimen. This was the WHO and NACO recommended regimen. But then came a game changer where we have integrase inhibitors like deltagravir, dolutegravir, elbitagravir, which cause a more than 2 log reduction in the viral load. And there were a number of studies which came with dolutegravir, single study, flamingo study, spring study, and data from more than 3,000 patients showed that. I will spend some time on this slide because dolutegravir is important. This shows that with dolutegravir, there is a rapid viral suppression. Within 4 weeks, you can achieve a viral suppression compared to 12 weeks with efavirenz. Discontinuation rates with dolutegravir are less than 2% compared to efavirenz, where the rashes were more than 13%. Neuropsychiatric events were much more than efavirenz. However, insomnia is reported more frequently with dolutegravir. But important point is that there are no known drug emergent resistant across different trials with dolutegravir. Drug-drug interactions are very minimal, except for with rifampicin, where we need to increase the dose of dolutegravir to twice a day. And important point, dolutegravir is effective against HIV too also. So in 2019, the regimen changed to preferred regimen became tenofovir, lamivudine, or emtricitabine, but in India we use more of lamivudine. It is much cheaper with equal efficacy with dolutegravir. So it is called TLD, tenofovir, lamivudine, DTG, which is the preferred regimen. Alternative regimen still there, efavirenz, but not in the dose of 600, but 400 milligram. It's a very safe drug, minimal side effect, insomnia, headache, dizziness, tiredness in less than 5% of the patient. But important thing which is coming up now is DTG-associated weight gain, where there has been a 5 to 7 kg of weight gain, which is initially very good in PLHIV, where they have a lot of weight loss and because of nutritional and other issues, weight gain is an important thing for them. But over the years, if weight gain becomes too much, then there are issues related to emergence of obesity-related complications. Very few drug-drug interactions. Most common is with the metformin. We have to limit the dose of metformin to 1 gram when used with dolutegravir. we have to be very careful because people take these drugs very commonly over the counter, antacids, multivitamins, supplements, and all of them have got drug-drug interactions and lead to reduction in the bioavailability of dolutegravir. So these need to be taken 2 hours before or 6 hours after DTG. And these are very important points that we need to actually tell the patient on the counseling, because prescribing is important, but adherence is more important. While giving tenofovir, we need to monitor serum creatinine level and see the creatinine clearance levels. This is we know all CG formula, how to create creatinine clearance. I will not go into details. So to summarize, NACO has taken up these guidelines from WHO, implemented them since 2020. Preferred regimen is TLD. Even for second line, people who are failing on efavirenz-based regimen, first line regimen, DTG is the preferred drug in the second line rather than protease inhibitor. And DTG along with darunavir, ritonavir is the third line regimen also. Now this is approved for pediatric patients also who are weighing at least 3 kg and are at least 4 weeks of age. And now DTG 10 milligram is available in India also. And very soon this will become available in national program. So consideration before starting treatment. These are some of the last slides, but very important that patient should be adequately prepared. Consent should be obtained from the patient and caregiver. Treatment should be based on his informed decision. He understands that it's lifelong therapy. There could be some minimal side effects. There is a caregiver identified. We had provided them CPT if their CD4 count is less than 350 and taken care of opportunistic infection prophylaxis. So we need to tell these 5 points that it is a lifelong therapy, adherence is important, drug toxicities may still be there. So what, when, how, who must be explained to the patient. Spend some time on patient on this, more important than just prescription. There are ways for patient to tell that they can put up SMS reminders, they can put up clock reminders. There are bottles which will tell them that they've taken the pill today or not. Lastly, coming to healthcare providers, needle stick injury. Again, now the regimen has been changed post-exposure prophylaxis with tenofovir, lamivudine, efavirenz. It has now changed to dolutegravir. So TLD is the regimen, preferred regimen for post-exposure prophylaxis for healthcare providers and even victims of sexual assault. So we are coming to last part. We said CD4 is not required for initiation of treatment. Yes, it is not required, but it is required now for identifying patients who are having advanced HIV disease, because 1/3 of the deaths, 1/3 of the patient present with advanced HIV disease, that is CD4 count less than 200. And these are the people who have got a very high mortality. So in this group of patients where the CD4 count is less than 200, we need to do certain additional investigation, and that includes cryptococcal antigen, lateral flow assay to identify cryptococcal meningitis or cryptococemia, urine for LAM, for TB, so that we can prevent them. TB preventive therapy, which is now using rifampicin and INH rather than just INH, cotrimoxazole, and also fluconazole. Even if we are not able to do cryptococcal antigen, CD4 less than 200, we need to provide them fluconazole preemptive therapy for those who have got CD4 less than 200. So that more or less summarizes my talk. Pre-exposure prophylaxis is another part, though this is not a part of the management, but since Dr. Chawla specifically mentioned, oral PrEP containing tenofovir is now offered as additional prevention choice in addition to condom for people who are at substantial risk of HIV infection. This includes anyone who has got a perceived high risk, or people, men having sex with men, female sex worker, injecting drug users, but anyone who has himself perceived risk, high risk of acquiring HIV. That sums up my talk on basically how do I manage a patient in my practice, but some of the updates, and I can't resist myself, that we have longer acting formulation coming in, fewer drugs, dual therapy coming in, longer acting formulation, injectables, 1 and 3 months injections, and that includes basically cabotegravir and ribavirin. But I can't go to cure because time is not permitting me. We cannot cure HIV with presently available drugs. It's a chronic manageable condition because despite viral load becoming suppressed below 50 copies even, The virus still persists in the T cells, macrophages, in gut, brain cells, spleen, and lymph nodes. So we cannot eradicate. So our goal is basically to have immune reconstitution, reduce opportunistic infection, and prolong the variant flying. Lastly, to summarize, remember it is a lifelong therapy. CD4 is not required for initiation, but it is required to diagnose and management of advanced disease. Treat all means all those persons diagnosed with HIV needs to be treated. Counseling is a very important component on preparedness. Recommended regimen is tenofovir, lamivudine, dolutegravir, and monitor patients on ART by viral load at 6 months after initiation and is suppressed then every month, every yearly. Thank you very much.
Thanks.
Dr. Chawla, sir, you are on mute. Please unmute yourself.
Can you hear me now?
Yes, sir.
Yes, yes.
Okay, great. I think Dr. Rewadi has done a wonderful job. In such a limited time, he has given almost all the information that is required to manage a HIV patient. And 2-3 comments I would like to make. One is that, ART has to be started as early as possible. Now, the current guidelines say preferably within 1 week of diagnosis. And if a patient is willing, at the time of diagnosis, when he's coming to the doctor with the diagnosis of HIV positive, at that time, ART, that should be done, And second important thing is, it is very important that everyone gets ART, whosoever is HIV positive. Because earlier there was a concept of, there was a group of people called as elite controllers. They were HIV positive, but without ART, they were able to suppress their HIV RNA. But these patients, they can have a long-term inflammation. So it is very important that you give ART to all the patients. And another important concept that has now recently changed, we were very much afraid of this iris. So now, for example, with tuberculosis, especially if CD4 count is less than 50, I think you start ATT and within 2 weeks, you can go on to ART. Suppose it is tuberculous meningitis, Usually earlier we used to wait for about 8 weeks before introduction of ART. But now what is recommended is that you start anti-tubercular therapy along with steroids, high-dose steroids, and then again within 2 weeks, you can start ART. Similarly, for cryptococcosis, now the period has been reduced to 4 weeks because with availability of these newer regimens, especially, for example, INSTIs, what we call as integrase 10 transfer inhibitors, the incidence of virus that is reduced a lot, and these are considered very safe. And one final point I would like to make, and I think I would like opinion of Dr. Rewadi also. You said 3 tests are required for making a diagnosis. But now with the availability of highly sensitive 4th generation test, for example, which is, detecting P24 and HIV1 and HIV2 antibodies. If it is positive, then you go on to the antibody differentiation immunoassay. And if it is positive, say, for example, for HIV1, it is HIV positive, or positive for HIV2, then it is HIV2 positive. Only if the second result, that is indeterminate, then you need to go to, this HIV RNA levels. Otherwise, I believe 2 tests, they are sufficient for making a diagnosis in today's concept. So over to you, Dr. Rewadi.
Yeah, Dr. Chawla, that is a very important point that you have made basically. But the 3-test algorithm has got certain scientific basis. Why do we do this? Basically, it depends first thing on the prevalence in the country, in the region. Secondly, we don't want to have anybody labeled as a false positive because the sensitivity of the test is 100%, but specificity is 99.9%. And the current recommendation is a 3-test antibody. Antigen antibody tests have become available, but this is not the recommendation from WHO or even from the National AIDS Control Organization. We do 3 antibody tests, which are sequential tests, and RNA is not required. We don't do a viral load for confirmation. We don't do a Western blot, and we just do antibody test in a sequential manner. If first test is negative, it is negative. If first is positive, you go to a second. If two are positive, you go to a third. But if there is a discordance between the first and the second, you repeat a second. If it is still discordance, you repeat after 14 days. But you don't go for a Western blot or for a RNA testing. So it has to be three antibody sequential tests on the same blood sample.
Yes, maybe we have not picked it up, but in JAMA in 2022, latest guidelines, they recommend what it is. Maybe in India, we are not doing that.
Yeah, there are different guidelines. Guidelines come from British HIV Association. They come from CDC. They come from US guidelines, also CDC. But most countries follow the WHO guidelines, and NACO also adopts WHO guideline. So I think as physicians organization, we should go by what is the national adopted guidelines rather than creating a confusion in the mind of people. So it is very simple. These are cost effective, and these strategies have been well tested in the country. And the algorithm, 3 test algorithms have been validated also.
Dr. Chawla, can I make a question?
Just
Yes, sir. Please go ahead. Please go ahead. Go ahead.
Okay, please go ahead.
Dr. Shibendu here from Calcutta.
Yes, Shivendu.
Yeah. The thing in India, I think it's a peculiar one. I do not know how to manage it. Most of the people in India, particularly, there's a guideline that you should not disclose the HIV positivity to the patient or their relatives. Where in the Western countries, we have to disclose the disease to the patients as a routine or mandatory one. It's my first query and first comment rather. Second is about steroid, anti-tubercular drugs and HIV. Though iris is common, pretty common, but most of the anti-tubercular drug, if we given with steroid, the incidence of hepatitis, but drug-induced hepatitis, increase almost many-fold. So should we advise steroid routinely with anti-tubercular drug for the fear of iris? And fourth is about another fellow who was describing about the infection. A large number of patients have increased intracranial tension. If we treat the patient with toxoplasmosis without presumptive diagnosis of increased intracranial tension with other drugs like mannitol, steroid, they increases the incidence of increased intracranial tension too much. How do you manage that? I think these are the 3 questions, I think. 1 comment and 2 questions.
So Dr. Shibendu, you have raised very important question. First is disclosure. Of course, you have to disclose to the patient. I think I heard you wrongly. You have to disclose to the patient that you are HIV positive. Perhaps you meant disclosing to the other family members. So yes, disclosure to other persons have to be with the consent of the person. You cannot disclose the HIV status of the person to another person without the consent, except there are some situations like when the person is going for marriage, he doesn't want to disclose his status, and then you have to come in and you have to counsel. First, you have to counsel to disclose. Also, it is important because I said when you start ART, you have to identify a caregiver. So it is very important that you counsel the patient that this has to be disclosed, but you cannot disclose it without his consent. Second point was on steroid. No, we don't recommend use of steroids when you are using ATT and antiretroviral drugs. As Dr. Chawla already mentioned that you wait for 2 weeks, you start ATT first, observe, and then you start antiretroviral treatment. The third point was
Please go ahead, Dr. Rewadi, go ahead.
Third point, I think Dr. Pulin may like to answer.
Yeah, thank you very much, sir.
This Pulin, just one moment, Pulin. Regarding this steroids, I did not say to give to every patient. Only if it is tuberculous meningitis.
Yes, that is very clear.
Not to patients with, say, for example, pulmonary tuberculosis. Only if there is tuberculous meningitis, not otherwise.
A person with HIV, with TB should be treated similarly as for HIV negative. That is the broad thing.
Absolutely. And I think that time Shivendu has raised one point. I think we have reached that stage because, basically most of the transmission is, happening from these people only, HIV, those who have not got their, test done. So I don't know, in the West, they have, probably they are going in for universal screening. And that way, if they pick up, and now that stigma that it is an untreatable disease, that is no longer true. So I think there should be some change in policy at the over end also. At any point of contact with a doctor, this HIV test must be, I think offered to the patient. That counseling part, taking consent part, probably maybe, I don't know, government authorities, they may be in better position to talk, because that is the only way to, finish it. Because if everyone is aware of their HIV status and are taking these safe antiretroviral therapies that now are available and keep their virus suppressed, only then we'll be able to, eliminate this. Because otherwise status is not known, and that guy, if continues following high risk behavior, that creates a problem. So I think that some policy change should be there, that it should be offered to each patient at point of, first medical contact, wherever it is.
Dr. Chawla, this has been long debated. It is not a new point that you have made basically. So, our prevalence is 0.21% only. We have only 22 lakh estimated PL-HIV, and we have a population of 140 crores. So there is an entity called provider initiated testing and counseling. So whenever a person is coming in contact with a medical person, it is for the medical person to decide. Nobody prevents him from testing, but not as a mandatory testing. It is an issue of human right, which is guaranteed under Constitution, Section 21 of the Constitution, that you cannot do a test without the consent, first thing. Secondly, it won't give you that yield. You have to do 140 crore tests to test everyone if you want to suppress the virus and what you say to eradicate the virus that way. And that test will tell you their status on that day only. Your person has come to you, have tested, and he goes back in the evening, and if he is a high risk behavior, so you will miss
that part has to be addressed. Definitely,
so point is, a provider has always a right that if this person seems to be at high risk or some diagnostic illness, some pointer, you should test. PITC, provider initiated testing counseling, is a very important part of HIV detection, because 30% of the people who come to treatment centers have been to a medical practitioner in the past, and they have been missed. Misdiagnosis is a very important part. That is why they come with low CD4 count. So your point that way is correct, but mandatory testing by everyone, I know you don't mean it.
Dr. Chawla, can I ask one question, sir?
Dr. Pulin has to answer one question. Then
Yes,
pull in, sir. First, pull in.
Sir, as far as the role of steroids is concerned, obviously steroids are not meant for pulmonary tuberculosis, but if it is a CNS tuberculosis, meningitis, or any patient presenting to you with an inflammatory edema, because the people will not die because of the parasite, because of the fungus, they will die because of the increased intracranial tension, midline shift, and coning. Coming to cryptococcal meningitis, again, it is not routinely commended, because in tuberculosis, it's a small, very, very small bacteria. However, fungus is a big one, and the fungal debris over the arachnoid granulations is not reduced by steroid given empirically. But if it is a severe intracranial edema, obviously the propped up position, oxygen inhalation is good. But in these conditions, rather than steroid, the better option is a therapeutic drainage. Steroid may help in reducing some edema, but it is more or less more for tubercular meningitis rather than cryptococcal meningitis.
Sir, therapeutic drainage can increase the incidence of herniation. I think that is also a difficult problem.
Yes,
because
sir,
what happens if a patient has got, say, for example, neurocysticercosis, what happens if you do not prime with the patient with the mannitol and steroid before starting with the drugs, neurocysticidal drug, they will increase the intracranial pressure to that extent that it can cause herniation. And even a patient has got increased intracranial tension, if you consider drainage, it can also induce one herniation, both ankle as well as subtentorial herniation. So
yes,
before doing the procedure of drainage, I think this is a very important, and drainage, CSF drainage is not a very easy procedure, safe procedure in a patient having increased intracranial tension.
it should be guarded. Obviously, yes, you are absolutely right. It should be
Shivendu, I think in these cases, you may have to go in for drainage multiple times to reduce pressure. CT is a good enough, investigation to see that it is safe. So you may have to, do multiple that thing. So basically, it depends on individual patient. You have to be cautious.
Yeah. Okay.
Yes, but you may have to do multiple, taps.
Yeah.
Okay, there was some other question.
Chavla?
coming in. Yeah.
Yes,
Dr.
Dr. Bhardwaj,
Chavla?
go ahead, please. Dr.
Anji,
Bhardwaj.
Anji, sir. I had a question that 2-3 years back there was a report about neural tube defects with dolutegravir, and it was recommended that in certain countries they are now even giving alvitegravir with Covistat.
I think
Uh,
Dr. Rewadi will give
what is
an
the
answer to
latest?
this, but I'm sure that with later studies, it has been found to be safe. Earlier, we were not recommending it in pregnancy, but now
Yeah.
it is the preferred drug therapy in pregnancy also. So
That's good, that's
that concern has
Yeah.
been taken care of.
So, Dr.
Yeah,
Chavla,
another-
you are right. It has got two answers to do. Women who are diagnosed with pregnancy and then diagnosed with HIV, their neural tube has already closed, so there is no issue. It is for those women who are already on dolutegravir and become pregnant, because neural tube closes in 28 days. And as you rightly said, this study is called CPAMO study. Basically, this was there were initial concerns when there were 3 or 4 cases out of 115 pregnant women on ART. But larger results have now shown that this neural tube defect is slightly higher than efavirenz, but the benefit that you get from dolutegravir are immense.
Much
So
higher.
still women have to be counseled, but this is the preferred regimen for even women of reproductive age group. But if a woman is already pregnant, there is no issue. Neural tube has closed in 28 days. By the time you detect pregnancy, it is already closed.
Right, sir.
With
Sir,
other
another
integrase stand inhibitors, for example, with bit-telgravir, and I think there is one more.
Bictegravir
We
and
don't have
alvitegravir.
much
alvitegravir.
experience,
LV.
yes, with in pregnancy, but dolutegravir is safe.
I had
What about
I had a
Lanavirol?
comment for neural tube defect. Dr. Ribadi, if you do not, do you have time to talk to? Can I?
Yes,
Carry
yes.
on.
The
Shivendu, we
most
are free.
important cause of neural tube defects in India,
Folic
at least,
acid.
it's a vitamin deficiency.
Folic
Mostly
acid, B12 deficiency.
B12 and folate is the most
Folic
important
acid,
cause.
Yes,
folic acid.
So
yes,
if we can
yes.
manage that, I think dolutegravir is not a problem to a great extent.
Yes,
Okay.
you're right. Absolutely right.
Thank you.
Can-
Thank you, sir. Thank you.
Can I ask a question, Dr. Chavla? If you,
सर मैं स्पीकर नहीं हूँ, स्पीकर डॉक्टर रेवाड़ी हैं.
sir,
कोई नहीं, मैं
Thank you, sir.
कोई नहीं, आप
मॉडरेटर को भी तो टेस्ट करना पड़ रहा है सर.
वो ट्रिपल टेस्ट मेरे पे ही मत करो ना, ट्रिपल टेस्ट.
Dr.
बताओ.
Rewari,
हाँ,
Dr.
Yes,
बोलो,
yes,
Rewari
please go ahead.
and
Please go
Dr.
ahead.
Dr. Rewari and
please
Dr.
go ahead.
Pullen, very nice presentation as expected from you. I've got a small query. In a
Thank you.
patient with cryptococcal meningitis, freshly diagnosed case of HIV, after how much time should we start HART?
For cryptococcal meningitis, the guideline is you should first complete the course of cryptococcal meningitis induction therapy, and then you can start antiretroviral therapy. That comes to around 14 days of treatment with induction therapy, and then you start treatment with antiretroviral therapy.
Exactly, sir.
Okay.
The induction therapy is 2 weeks, then the consolidation is 8 weeks. And so initially, as Dr. Chavla said, previously it was after 4 to 6 weeks.
14.
But now it is said that it can be started after 2 weeks, provided
weeks.
the patient is not having any seizure. There is no evidence of intercant tension. He is conscious or taking orally. We need
Yeah,
to
that is the after induction phase. Induction phase is 2 weeks.
after
basically.
2 weeks.
Thank you. Very nice presentation.
Dr. Rewari,
Dr.
we
MP?
have got a question. Sir, sorry. Yes,
नहीं, बोलिए आप,
Parikh.
बोलिए. Please. please,
I
continue.
have got a patient of pancreatitis with HIV positivity. Is there any contraindication of dolutegravir for those patients?
Not with dolutegravir.
pancreatitis.
There used to be
Stavudine.
pancreatitis with adenosine. There used to be with stavudine. They used to call this pancreatitis, but those drugs are not taken off. So
Yeah.
dolutegravir, when your liver enzymes are raised more than 3 to 5 times, then you have to be cautious, cautiously monitoring patient on dolutegravir. Otherwise, there is no contraindication.
Now,
Dr.
what's
Shridu,
about the
if your patient is having chronic diarrhea and pancreatitis, please rule out Cryptosporidium and Isospora. They have a predilection for pancreatic ducts also. They can cause pancreatitis. Please rule out those. Get a fecal cyst examination done.
That is important point.
Now, what's about drug-resistant tuberculosis and HIV? Do you find any, like your bidacolan and others are safely used in patients of drug-resistant tuberculosis?
Bedaquiline has got no drug-drug interaction with dolutegravir-based therapy.
Oh, okay. So there is no problem that any drug
There is
or
no
second
problem.
line or third line drug can be used
Yes,
safely.
they can be used. They can be used safely.
You have to be cautious about drug interactions, especially, for example, dolutegravir that is increased to 50 milligram twice a day.
No, that is with rifampicin.
Yes, that is with rifampicin.
Yeah.
Or second option is you can change rifampicin to say rifabutin 150 milligram daily. So that will eliminate that drug interaction also.
Actually, rifabutin availability is a big issue. It is not available in the market, neither in the program.
मैं डॉक्टर रेवाड़ी अब आंसर तो देना है ना बॉस. अपनी तो पॉलिसी है कि nobody should go back with a query in the mind.
No, that is very important.
Very good.
So MP, I think we have had a wonderful discussion, and probably Dr. Parikh wants to say something, and then we can close.
We had a very good discussion, and I mean this is the interaction between the speaker and the moderator and the delegate. I mean, this is so important that makes the CME very powerful.
Exactly, sir.
Thank you, sir.
So it is often said that better than 100 days of diligent study is one day spent with a great teacher. And Dr. B.B. Rewari and Professor Pulin Gupta are those teachers for HIV. They've hit the ball out of the park just like Ravindra Jadeja did in IPL finals. Won the penalty.
Correct.
Great.
Thank you very much, sir. Thank you, Dr. Chawla, Dr. Parikh, Dr. Rewari. We can see your faces from a distance. Thank you. Very good presentation. Yeah.
Is there any communication from the headquarters by the secretary, Dr. Suresh Peshwa? Would you like to say something before I ask Dr. Parikh to propose the vote of thanks?
Next meeting on the ABG, blood gas analysis,
sure,
by Dr. Sanjay Pandya from Rajkot.
Good.
Where?
Any electrolyte, go to Sanjay Pandey.
Yes.
From India, it's going on.
So this meeting where, Dr. Suresh?
Yeah.
ठीक है सर, close करो आप.
नहीं, कहाँ पर है डॉक्टर इलेक्ट्रोलाइट इम्बैलेंस में?
नहीं सर, आप next Zoom meeting.
Next Zoom meeting, yes.
We can keep that. We'll keep it. I'll now request the president.
Decide करेंगे, पर वो ये है कि we have to keep very interesting topics because देखिए जरा सा सरकते ही कम हो जाते हैं delegates. So it is very important to know the delegates' mind.
Exactly. I'll now request Dr. K.K. Parikh, sir, the president of IACM, to propose a vote of thanks.
So thank you, the learned speakers. They have very nicely given excellent deliberations and given in a very simple way the message to the delegates, to the clinicians. I mean, so clear message that one can understand. And thank you so much. Both the speakers done a great job, Dr. Pulin Gupta and Dr. Rewari as such. And the chairpersons, Dr. Chawla, Dr. Dev Chakravarti, and Dr. Narsimlu. Thank you very much for sparing your valuable time, and thank you, delegate, because without you, the CME cannot be successful. It is all the attending delegates which makes a successful CME program. And again, I will thank Dr. MP Singh for his great efforts for organizing every month such CME programs. And I mean, really, it is going very good. Attendance is always good, more than 100 every time. And thank you very much, everyone. Sorry, the last announcement I said that it is 26th July. No, it is 29th and 30th July, Saturday and Sunday at Hotel Hilton. IACM program, Saturday and Sunday. The program will be sent to everyone, and I request everyone to kindly attend the program of IACM at Jaipur on 29th and 30th July. At 10 o'clock it will start. Thank you very much. The detailed program will be sent to you.
And I think, sir, I would conclude by saying, I think you have such stalwarts like Dr. Parikh, who's, he has been instrumental in making C amount of change in working of IACM and has brought it to the level of even API, and he's so much interested and he has, been leading by example. Thank you, sir. Thank you very much.
Thank you so much, sir. Thank you for your kind words.
Thank you, Dr. Parikh, sir.
Yeah, thank
Your
you, sir.
wisdom
Thank you.
and foresight.
Thank you, sir.
We
Good
echo
night,
Dr. Sarla's
everyone.
words.
Thank you, everyone. Thank you for joining us.
Thank you,
Good
sir.
night.
Thank you.